Well, hello there. This is Professor White, and today's lecture will be on antibiotics. This is part one of a two-part series. Bacteria are single-cell microorganisms that are very diverse. They have many different shapes and features, and they can live in basically any environment, including inside of the human body. Not every bacteria causes infection, but in those that do, it's called pathogenic bacteria. One of the ways that we classify bacteria is whether or not they have a cell wall, whether they are gram-positive or gram-negative. So this is called gram staining, and it helps us decide which antibiotic would be best suited for a certain bacteria, because some antibiotics work on that cell wall and some do not. Infections can be described as being from the community or associated with the healthcare that the patient has received. Community-associated infections, you can see here, basically is an infection in a person that has not been hospitalized or had a medical procedure in the last year. Healthcare-associated infections, which used to be called nosocomial, and sometimes you'll still hear that, are related to when a person gets care or occurs soon after getting care. They are a serious threat to healthcare safety. And in fact, preventing healthcare-associated infections is one of the top priorities of the CDC and also for healthcare in general. One of the other differences between the two is that community-associated infections tend to not be those drug-resistant strains, where hospital-acquired or healthcare-associated infections tend to be those types that are harder to treat. They have more drug resistance and spell disaster for a lot of patients. Healthcare-associated infection prevention is one of the priorities that we all have a part in as nurses and aspiring nurses. And many of the infections that we're attempting to prevent for healthcare-associated infection would be those central line infections, catheter-associated urinary tract infections, surgical site infections, and ventilator-associated pneumonia. One of the best things that we can do is to do our appropriate hand washing, understanding that hand washing is the pillar of healthcare. It's great to foam in and foam out with the antibacterial hand wipes and things of that nature and the gels, but there are certain bacteria like C. diff where that will be completely ineffective. So making sure we know when to wash our hands and for how long is very important. Another concept is the antiseptic concept. So antiseptics primarily inhibit microorganisms, but they don't really kill them, and they are applied exclusively to living tissue. So this would be like the antiseptic wipes that we do for patients prior to surgery, antiseptic mouthwashes, things of that nature. Disinfectants, on the other side, those are able to kill organisms, and they are only used in non-living objects. So this is when we disinfect a surface. One of the antiseptics that we commonly use in the hospital and for patients is called povidone iodine, or PDI. Anything with iodine, the one thing I want you to remember is that just like people who are getting CT scans with iodine, if they have a seafood allergy, we don't want to give them iodine as well. And a lot of times these iodine sticks are just kind of sitting in supply rooms and things, so make sure you check allergies before using iodine on any patient. Antibiotics are used to treat only bacterial infections. They will not work against viruses. And something to note is that you must obtain the cultures prior to starting antibiotics. Otherwise, it will render the culture and sensitivity that will be run as ineffective. What we're looking for with giving antibiotics is that the person improves, so that there's a decrease in their symptoms of infection, or perhaps if they were giving it preventatively, that there would not be the development of infection. Subtherapeutic, just as the name implies, means that it was not effective. The symptoms did not improve. 3 more terms for you to be aware of are empiric therapy, definitive therapy, and prophylactic therapy. So empiric therapy means basically a broad spectrum approach, knowing that a patient is ill and they must get some sort of an antibiotic. Even though we may not have the culture results, we'll treat them with more of a broad spectrum. As we are able to narrow down the actual offending microorganism with culture track, that's when we go into definitive therapy. And at this point, the patient may or may not be on the best antibiotic. If they are not, we expect that they will be changed to the antibiotic that would be appropriate to the microbe that was identified in their culture and sensitivity. Prophylactic therapy is basically treatment to prevent an infection. Some of the considerations that we should be aware of regarding antibiotic therapy are listed on this slide. One of the first is superinfection. So although antibiotic-associated diarrhea is common, it becomes a serious superinfection and can cause antibiotic-associated colitis. So it used to be called pseudomembranous colitis, but currently it's called Clostridium difficile or C. diff infection. And just like you may be aware of when we have an overgrowth of bacteria when we use antibiotics, which is one of the reasons a person gets diarrhea, and also why yeast infections are common in females. C. diff also starts the same way because the antibiotics are disrupting the normal gut flora, and that causes an overgrowth of Clostridium difficile, which is in 25% of people anyways. The most common symptoms of C. diff are that profuse, loose, watery diarrhea, abdominal pain, and fever. So anytime a person who was previously treated with antibiotics develops watery diarrhea, we should have a high index of suspicion for it being C. diff, and we can test the stools for that. And if indeed they do have that infection, then they would need to be treated for that infection, usually with oral vancomycin. There's the risk of a secondary infection on our patients. We talked about drug resistance a little bit, but there are a lot of drug-resistant organisms that are out there now that require enhanced precautions in the hospital. Many food-drug interactions, so antibiotics interfere with a lot of like vitamin K, so green leafies. There's problems sometimes with milk and dairy, other medications including phenytoin, warfarin, you name it, there's going to be an interaction there somewhere. And then a lot of host factors. So some of our agents are bacteriostatic and not bactericidal, and that really means that the host has to be healthy enough to mount an immune system defense against these organisms as well. There is also an issue with allergies, especially penicillin and sulfas. So the most common severe reactions, these would be considered hypersensitivity reactions. They would be characterized by things like wheezing, shortness of breath, swelling of the face, tongue, hands, itching, and rash. If your patient is developing an super or a hypersensitivity reaction, you would need to make sure that you please stop the antibiotic and never leave a patient who's in distress. So you need to check for allergies prior to giving antibiotics, understanding that there are some cross-sensitivities out there. Certain antibiotics are safe during pregnancy, like our penicillins. Others are not. G6PD is a type of genetic hemolytic anemia. So that's a mouthful, but what it means is that some folks, they have an inherited genetic condition in which exposure to certain medications, among them antibiotics, namely some of the ones used to treat UTIs, can cause the person to have a hemolytic anemia where their body starts to destroy their own red blood cells. And then, of course, the site of infection has something to do with what antibiotic is chosen and how well it works. For example, in the case of things like chronic osteomyelitis, there's bone sequestration there. It's very hard to get as much antibiotic to the site of the infection as opposed to something on the surface of the skin where you can go after it topically. All right, so here's a lot of the classes of antibiotics that we'll be learning about. We have our sulfonamides, penicillins, cephalosporins, macrolides, quinolones, aminoglycosides, and our tetracyclines. Antibiotics are further classified by what their actual action is. So remember, an antibiotic may be bacteriostatic, meaning that it inhibits the growth of susceptible bacteria rather than killing them immediately, but eventually does lead to bacterial death, versus bactericidal, which kills the bacteria. So the other classification is on whether or not the medication is considered broad spectrum or narrow spectrum. So broad spectrum casts a larger net and can get all sorts of different bacteria, where a narrow spectrum is really specifically targeted towards one or two organisms and is narrowed by culture track. I found this slide and I thought it interesting if you wanted to pause here and take a look at it for a little bit. Basically tells you the mechanism of action for a lot of the antibiotics. For example, many of them inhibit protein synthesis. Some work on the cell wall. Some inhibit folate, like the sulfonamides. So basically, we have an interference with cell wall synthesis, interference with protein synthesis, interference with DNA replication. Some act as metabolites that disrupt critical reactions inside the cell. Basically, a lot of different actions, a lot of different ways to go after bacteria, and it goes based on the bacteria's susceptibility. The first type of antibiotic that really did come to the market was something that was labeled as Protocil, but it was actually developed in 1932 by a fellow named Gerhard Domag, and he was in Germany, and basically doing a lot of mice bacteria, these sulfonamides, which were from dyes, okay? They were used from dyes to dye fabric. It was found that they could counteract the blood poisoning that they were giving to the mice. So this was the first really commercially available antibiotic. When it came out, it was very, very revolutionary to be able to find this. This is one of the reasons that a lot of people started to survive that normally would have died. So sulfas nowadays are generally combined with trimethoprim, so a sulfa with a non-sulfonamide. So these are called Bactrim or Bactrim DS double strength. Often you can see the abbreviation SMX TMP because of the name being so unwieldy. So let's look at the mechanism of action. Sulfas are bacteriostatic, and basically they interrupt folic acid synthesis, and therefore the way it does work leaves the human cells alone. Let's look at some of the indications. So the sulfa antibiotics are really good at both gram-positive and gram-negative bacteria. Their common use is to treat UTIs because of the type of bacteria that normally cause UTIs are very susceptible to the sulfa antibiotics. Using Bactrim is also a treatment for pneumocystis jirovecii, or that it's a terrible type of pneumonia that is pretty specific to our really immunocompromised patients, including those with HIV and AIDS specifically. And it's also used for upper respiratory tract infections. So again, the main reason that we will give this to patients is that for a UTI. Let's look at some of the other issues with this.
remember that an allergy would be an absolute contraindication to any medication. There might be a cross allergy to sulfite preservatives. This one is not to be used in pregnancy, not for infants under 2 months old. In the case of our sulfonylureas, these sulfonamides can kind of potentiate that hypoglycemic effect, which makes it more likely that our patient would experience low blood sugars. It can also increase the toxic effects of phenytoin. It can increase and enhance the anticoagulant effects of warfarin. And they can also reduce the efficacy of oral contraceptives. Some of the adverse effects, of course, would be that hemolytic or aplastic anemia, which we sort of touched on as a G6PD deficiency. So that would cause the hemolytic anemia. Stevens-Johnson syndrome, particularly with topical application of the sulfonamides. Nausea, vomiting, and diarrhea. Pancreatitis, of course. Some of the other issues that can occur would be sometimes photosensitivity, agranulocytosis, which means that the patient would not be able to make white blood cells, sometimes thrombocytopenia, where it's a decreased platelet. It can cause liver and kidney disorders, as well as crystalluria, so the buildup of crystals into the urine. So the critical information that we should take away from the sulfonamides is that the patient should drink plenty of water with the sulfonamides to avoid crystalluria. And if the person is on this antibiotic for any great time frame, then we should be doing periodic blood tests to check for their white blood cells, red blood cells, and platelets. So this slide may have been better pushed behind the penicillins, but it sits here, so we'll keep it here. So our beta-lactamase inhibitors, basically these are little boosters for the penicillins, which we'll speak of next. Basically prevents the breakdown of the penicillin molecule. So many of our penicillins that we give intravenously are combined with the beta-lactamase enzyme. So most common that you'll be giving probably would be ampicillin with sulbactam or unicin. By mouth, we're used to seeing augmentin or amoxicillin with clavulanic acid. My favorite is piperacillin tazobactam, which we call Zosyn, is the name brand, which it's still known by that because of the Zosyn shake. It's kind of hard to mix up. But I digress. Let's go on. So this fine fella here looking dapper in his bow tie is Andrew Fleming. So he actually discovered penicillin in 1928 at St. Mary's Hospital in London, but it took about 20 years for it to actually be made into the mass-produced drug that we know today. It was discovered because of a moldy petri dish. So basically our penicillins, what they do, and the prototype will be penicillin G. It's bactericidal. It basically acts by binding to the penicillin binding proteins. It weakens the cell wall, and that allows excessive water to enter the cell and lyses the cell. So pretty interesting how it works. We have a lot of penicillin drugs available at this time. So you have here a big list of the penicillin drugs. Again, the biggest prototype that we should be aware of is penicillin G, but we do know the penicillins because most of them do end in -cillin, but don't let that fool you. Sometimes they don't, but most of them do. Let's look at the indications for using these. Penicillins are really good at treating infections caused by strep and staph. So streptococcus and staphylococcus, they're very common skin contaminants, so they would be big players as far as wound infections and otherwise. All right, let's take a look at some of the other issues with these. So penicillins are used to treat bacterial infections of infants, children, and adults. They're generally pretty safe, pretty well tolerated, but they're also among the most common causes of drug allergies that we have. So if a person has a known drug allergy, we would not want to have them take this medication. So if a person states that they have an allergy to penicillin, we need to make sure that they're having a true allergy, because sometimes what they have would be more of a side effect and not an actual allergy, which would be potentially cutting them out from the ability to have this medication in the future. So if a person says they're allergic, let's look into it a little bit more and see if it was an actual anaphylactic or an allergic reaction. And remember that not all penicillins end in -cillin. Most of them, Augmentin and Zosyn, would be examples. If you look it up, because they're a combination drug, they hold a different name, but they do have a -cillin in them. And this is why it's very important to use the generic names of medications for just that reason. You may not understand that a person has an allergy to penicillin when you say I'm giving them Zosyn, but if you say I'm giving them piperacillin tazobactam, then you may just pick that up. And we've already mentioned that these allergic reactions, very common. Make sure you're asking the patient, and then understanding that if a person's had any swelling or hives with penicillin, so if they've actually had an anaphylactic reaction, that they should not receive the cephalosporins. Otherwise, many common adverse effects, and people often will say they're allergic when they're just having an adverse effect, and lots of interactions, right? So interact with NSAIDs, oral contraceptives, and warfarin. It can make a person bleed more on warfarin. And also, if a person has renal dysfunction, they may need a decreased dose. Some of the other side effects, if we're giving high dose IV, penicillins can actually cause hyperkalemia, especially penicillin G. And anytime that we're giving penicillins, we do not want to mix them in the same IV or do any Y site for any aminoglycosides. All right, let's move on. All right, so our cephalosporins will be the next class of antibiotics. They are bactericidal. They act by binding to the penicillin binding proteins. They weaken the cell wall, which allows, again, excess water to come in and lyse the cell. They are very similar structurally and pharmacologically to the penicillin, so that's why they have the same mechanism of action. There are 5 different generations based on when they came into the market and how they're used. And again, remind yourself that because they are so structurally similar to penicillin, that they should not be given to patients with severe penicillin allergies. So the cephalosporins, they are grouped into these 5th generations, and you can see that I have them grouped here. Some are not as in favor anymore, so this is a little bit older, but let's look at some of the generations. All right, so the 1st generation, these provide very decent, excellent, good coverage for gram-positive, but not so much our gram-negatives. These are the ones that, because of what they cover, staph and strep a lot, that we'll be using it surgically for prophylaxis, especially staph infections. So these would be commonly given as a person has a surgical procedure done. Anytime we cut the skin, we'll usually give them a dose of cefazolin IV during their surgery, and for at least usually for 24 hours after. So there are some that are available by mouth. So cephalexin or Keflex is really good for skin infections, and cefazolin is used IV. The 2nd generation of the cephalosporins, that ending is the one that says basically everything else. So they have sort of different names. Though you'll have to see that there are 2 meds in here that buck that. So cefaclor, which you would think is 1st generation based on the Fa and Fa, or PHA, but that is actually a 2nd generation, and cefuroxamine, which you would think would be belonging in the 3rd generation, but it is 2nd generation. So just something to confuse us a little bit. So here's just a couple of drugs in the 2nd generation to look at. So cefoxitin is available IV and intramuscular. So often used before surgeries in the abdominal area. That's because of the anaerobic action, and think about the gut with a lot of anaerobic bacteria. And cefuroxamine, usually Ceftin is the by mouth that we may give, and it does not kill the anaerobes. The third generation, these are the strongest, right? So most potent against our gram-negative bacteria, not as active against the gram-positive. So gram-negative would be a lot of the bacterial invaders that we have. So it's considered that Rocephin that you see there, ceftriaxone, is considered a very broad spectrum antibiotic. So as we're waiting to treat somebody, we may be treating them with Rocephin or ceftriaxone and maybe a little vancomycin from one of the other class of medications here. Ceftonir is still used to this day. It is basically Omnicef. And I guess we can kind of pause there. We'll go on to a quick look at ceftriaxone. So ceftriaxone is available intravenous or IM. The thing that makes this a nice drug is that it only has to be given once a day. It's eliminated in the liver, and also it can go into the central nervous system. So ceftriaxone is going to be a very, very common antibiotic that you will basically be given fairly often, I would say. And again, it's the cephalosporins in general are broad spectrum, and ceftriaxone being the most common. Ceftriaxone can cause an increased risk of bleeding. So if somebody has a history of a bleeding disorder, just monitor them for that. Ceftazidime, we used to use this a lot more, but not as much anymore because there's a lot of resistance that's occurring to it. But it is used to treat Pseudomonas. It's really effective at our gram-negatives. So this was just another one of those third generations to look at. So the fourth generations, there's only one that you need to be aware of in here. That's cefepime, so it has the pi in it. So it is very broad, even broader than the third generation, really works against our gram-positive. So we would pull this guy out to treat those complicated UTIs more than uncomplicated, but certainly UTIs is what they are best known for. The fifth generation, we have ceftolozane and ceftaroline. So just a couple, just to recognize that they belong in there. These are the tolls and rolls. So ceftaroline is really effective against MRSA. So you're seeing that a little bit more used for that reason. So to wrap up the cephalosporins as a class, remember they're broad spectrum. They're overall pretty safe. Serious adverse effects are rare. They are very similar to the penicillins, and there is a cross sensitivity for those allergic to penicillin at up to 1%, which is not insignificant. Very rare occurrence of pseudomembranous colitis or C. diff, so that's a positive for these guys as well. So the carbapenem drugs, they are bactericidal. They act by weakening the cell wall, which once again allows excessive water to come in and lyse the cell. They are the very, very broadest of the broad that we have at the moment. So they are used to treat infections that are a combination of bacteria due to their broad spectrum. They are category risk B. So these are not absorbed well from the GI tract, so this must be given intravenously. May cause drug-induced seizure activity, so that's very rare, but it can happen. Allergic reactions can occur, and there is a cross-sensitivity for the penicillins here as well, but a lot of GI effects, including nausea, vomiting, and diarrhea. And here you have the exemplar drug, so it's imipenem, which we generally have the form that is mixed with the enzyme inhibitor. So cilastatin inhibits the breakdown of imipenem. And some of the others that you'll see would be meropenem and ertapenem, rather not as frequently, but you'll see them in the hospital for our complicated patients. Under the monobactams, there's only one drug in here. It's aztreonam. It is bactericidal. It inhibits cell wall synthesis. It is not absorbed from the GI tract, so it must be given parenterally as well. It is very narrow spectrum, so it works basically against aerobic gram-negative bacteria. It's given when a patient is allergic to penicillins. So what it can be used for a lot and often is treating UTIs, respiratory tract infections, and skin infections. Some of the side effects of the monobactams would be hypotension, nausea, vomiting, and diarrhea, and possible that elevated liver enzymes may occur. So you'd want to watch their... So the next section that we want to talk about would be our macrolides. These are not to be confused with the aminoglycosides. These are macrolides. So the way I always remember them is if they have throw in them, like erythromycin, azithromycin, you can throw them out because they're not going to be the big bad beasts that the aminoglycosides are. And you can compare this to the aminoglycosides once we talk about them. So the macrolides are bacteriostatic. Let me just get on to our next slide. They're bacteriostatic. They inhibit bacterial protein synthesis, and as a result, eventually they will die, but it does take a little bit to get them there. The macrolides are pretty broad spectrum, and they're used to treat a lot of strep infections and some of the spirochetes like syphilis and some of the other STIs. So again, pretty broad spectrum. The newest of the new is fidaxomicin. So that kind of balks the trend of the thromycin. But this is one that treats Clostridium difficile or C. diff. So just understand that it belongs there. So let's talk about these a little bit. So the macrolides, we can reduce their GI effects by providing meals when this medication is administered. This does work on that cytokine P450 system in the liver. So basically, you have to be careful if we're giving other medications that are affected by cytochrome P450. If the medication needs to be given with food, for our exemplar medication, erythromycin, make sure we use the enteric coated form. And then look at some of our side effects here. Most common are going to be GI effects, and that would be like epigastric pain, nausea, vomiting, diarrhea. There is a potential for the risk of cardiac death. In fact, I once took care of a patient who was prescribed azithromycin for an upper respiratory infection, and she took her dose and went into cardiac arrest, and her husband actually saved her life by performing high-quality CPR. There's a risk of superinfection. High-dose therapy can cause hearing loss, and there's the risk of thrombophlebitis as well. So again, these medications, they all have a lot of side effects and adverse reactions. So the tetracyclines, these are a fan favorite for sure. They're bactericidal. I'm sorry, they're not bactericidal, they're bacteriostatic. It inhibits bacterial protein synthesis. And basically, they are all known by having the cyclin at the end, so CYCLINE, so democycline, tetracycline, doxycycline, minocycline. They all belong to the tetracycline class. They are pretty broad spectrum, but mostly used as a second-line treatment option because of the effects of the tetracyclines. So
Some of the things we are aware of is that dairy products and acids and even iron reduces the oral absorption of the tetracycline class.
They're not to be given in children under 8 years old and pregnant women as permanent staining. So brown or yellow discoloration of the child's teeth or developing fetus's teeth can occur. There are some issues as well with hepatotoxicity, especially in pregnant women and anybody with kidney disease. They have a higher risk of hepatotoxicity.
Let's continue on just a little bit with the next slide.
There's a pretty strong affinity for calcium,
so that's why it can cause some issues with the fetal skeleton.
And as the same sort of concept that we should not be given this medication at the same time as any of the 2 positive cations. So these would be things like calcium, iron, magnesium, aluminum, or zinc. So we need to administer them at least an hour before or 2 hours after any medication or food or supplement containing, again, calcium, iron, magnesium, aluminum, or zinc. There is a photosensitivity issue with tetracycline as well.
People with renal disease should not receive tetracyclines. And our GI side effects can often be minimized by giving with meals. But give it with as small amount as possible because food decreases the absorption of the medication. So for all antibiotics, these are nursing considerations for them. First and foremost, make sure you know your patient's allergies before you give them an antibiotic. Please, please. All right. Medication error related to this is completely preventable by talking to your patients. Make sure we pull the cultures before treatment. Antibiotics should be given at the specified times for the duration that they are ordered. So make sure you teach your patients that, even if they're feeling better. Look for the signs and symptoms of superinfection, among which one of those is that membranous colitis, so C. diff. Look for drug interactions if your patient is on phenytoin, oral contraceptives, warfarins, things of that nature. Looking at the side effects, as some are very specific to the medication. And all oral antibiotics, we want to teach our patients to give them with at least a full glass of water, so 6 to 8 ounces. Here are some specific things. So our sulfonamides, we want to make sure that the patient's taking in 2 to 3 liters of fluid every 24 hours, and that's because of the crystalluria. Make sure we know the patient's baseline labs before we start therapy, because otherwise how would we know if there's a change? And the oral doses may be given with food. Best taken with food. Penicillins, we want to make sure that the patients know to take their doses with water, because if you take the medication with acids, it can decrease the action of the penicillin. And if we are giving penicillin to a patient through the intravenous route, don't just give it and then walk away. We want to make sure we're monitoring our patient for a full 30 minutes after administration. Some of the specific implications for our cephalosporins, to remind yourself that they may have a cross sensitivity to penicillin. These should be taken with food. And then there's something that's called disulfiram-like reaction. So basically, there are medications like Antibiotics that patients take if they're trying to abstain from alcohol use. And some of these antibiotics can cause sort of that same reaction. So our cephalosporins like cephalexin, metronidazole, which we'll talk about in our part 2, Bactrim can cause it. So basically, if the patient takes alcohol with those, it can cause flushing, headache, nausea, vomiting, fast heart rate. So severe vomiting may happen. The macrolides, highly protein bound, interferes with other protein bound medications.
remember, oral erythromycin is better taken on an empty stomach, but it causes a lot of GI disturbances, so a little food is okay. The less, the better. The tetracyclines, avoiding milk, iron, and acids, other dairy, because of the binding, it decreases the efficacy of the drug. Remember what we said about tooth discoloration in children and pregnant women. Patients should take these with water as well, and avoid any sunlight and UV exposure in the way of tanning beds for photosensitivity. All right, so this was a long one. Thanks for sticking with. Antibiotics are kind of tough. So I will leave you with this here cartoon about how good bugs go bad and become super bugs. Have a great day.